Dr. Jonathan Waters is currently a professor in the Departments of Anesthesiology and Bioengineering at the University of Pittsburgh, Chief of the Divisions of Anesthesiology at Magee-Womens Hospital of the University of Pittsburgh Medical Center, and a member of the McGowan Institute for Regenerative Medicine. In addition, he is a medical director of the Patient Blood Management Program of UPMC and medical director of the Blood Management Division for Procirca Incorporation, which is a UPMC-owned biomedical engineering company. Dr. Waters' areas of expertise primarily focus on transfusion management, blood salvage, and obstetrics. He has been federally funded to support investigation in these areas with over 150 peer-reviewed publications, 5 books, and topic of blood management, and a book on neurology disease in pregnancy. In addition to conducting research, he has served on the editorial board of the journal Transfusion and is currently serving as an associate editor. Dr. Waters is a past president of the Society for the Advancement of Patient Blood Management, that is SABM. He served on the board of directors of the AABB between 2011 and 2015. He chaired the board management technical advisory panel for the Joint Commission from 2007 to 2016. Dr. Waters was the recipient of the 2023 Award of Excellence of the Bloodless Medicine Surgery Society. I hereby present to you Dr. Jonathan Waters. Please, all ears are yours.
Well, thank you for that introduction. Can you hear me?
Very well.
Okay. Nathaniel and I have been exchanging emails all week because I was scheduled to present this on Tuesday of this week, and unfortunately I was caught up in operating room clinical care, and so we came to the idea that I should videotape my presentation, which I did, and tried to send it to Nathaniel, but because of the size, my university wouldn't let me transmit the presentation. It was 400 megabytes big, so it was a pretty sizable file. And so you see my picture in the bottom right-hand corner of the slide, and this is from the presentation that I made, that I embedded into the slides, and I can't figure out how to get rid of the presentation, given that now I'm doing this live. But anyway, I'm going to talk about bloodless care in oncology, and from my perspective as an anesthesiologist, this all has to do with autotransfusion, or what has been labeled cell salvage. So I live in the city of Pittsburgh, which is in the state of Pennsylvania, which I've highlighted here on a map of the United States. And I don't know, I think it's part of the presentation is working without me controlling it. But this is a picture of the city of Pittsburgh, which is sits at the confluence of the Allegheny and the Monongahela River. And right here, between our football stadium and our baseball stadium, is this plaque where the Jehovah's Witness Church was first created. And so because of the origins of the church, we take care of a very large number of bloodless patients at our hospital system. In fact, we take care of about 1,600 a year that come through our doors. and this is happening automatically for some reason. I apologize for that. But at any rate, autotransfusion comes in many forms. These are some of the pieces of equipment that you can use. And this group of devices do batch processing, meaning that there are batches of blood that are processed um, where the blood is collected, concentrated, washed, and given back to the patient, whereas the Fresenius cats does it in a continuous pattern of processing. And the cats has used this marketing, or rather the idea that their device processes continuously as a way of marketing their device to bloodless patients. And I've had many conversations with the leadership at the Watchtower, and this is not necessary from their perspective. So the big question that hopefully we can get to some understanding of is, does this collection of shed surgical blood concentrate tumor cells, which could lead to massive disseminated metastasis? And this concept or idea arose from this case, a single case report that was published in JAMA back in the 1970s, where they reported on a 52-year-old individual who presented with lung cancer. And it was a stage 4 lung cancer. And at any rate, he underwent surgery, had blood processed and reinfused, and died three weeks later. And it was blamed on the autotransfusion, creating the massive disseminated metastasis that he experienced. Now, question is, do you base practice on a single case report? And I personally do not. I like to look at larger scale studies than single case reports. There's an individual, Ernil Hansen, who practices anesthesiology at the University of Regensburg in Germany, who feels that the tumor cells in salvage blood may be dangerous for patients. And he did this work where he looked at multiple different tumor types and the blood that was collected from the surgical field, and found that he could find tumor cells in the shed blood in concentrations that ranged from 10 to 10 to the sixth. One of the interesting things that he also found was that 26% of these patients had circulating tumor cells already in their circulation. So the question really arises is, what is the difference between the tumor cells that are in the autotransfused shed blood versus the tumor cells that are already circulating in the patient? So now one of the things that I advocate is the use of filtration to remove the tumor cells. And this is a leukocyte depletion filter that can be used for this purpose. This particular filter works by using a depth or multiple layers. This is really frustrating. The slides are moving on their own. Anyway, it's a depth filter, and there's a couple of different biological filters that we have or encounter in the surgical world. One of them is a screen filter, which you would find in a autotransfusion blood collection reservoir. It's also the cardiotomy reservoir that's used in cardiac surgery. And this is what a screen filter looks like under magnification. It basically looks like a window screen where you have holes that anything larger than the hole will not pass through the filter material, whereas anything smaller will. Now we have the leukocyte depletion filter is actually a depth filter, and this filter works through a depth multiple layers of polyethylene fibers that basically the red cells have to transit as they move through this filter. And this is a slide that shows you how the filter material changes as the blood flows through the filter material. So the picture on the left shows the density of the polyethylene when the blood first enters the filter, and then the shot on the right shows how the density of the polyethylene fibers changes. So these filters work through two mechanisms. One is the dictated by the pore size, as does the screen filter, but there's also adhesion that takes place to the polyethylene fibers that's driven by the surface charge of the red cell. And blood cells or red cells have different surface charges than the other cells in our bodies. The red cells are designed not to stick to each other, whereas all of our other cells are designed to stick together. So there's been a whole bunch of studies that have looked at whether or not these leukocyte depletion filters remove tumor cells. And this is 4 of those studies where they showed complete removal of the tumor cells. And so the question comes down to whether or not this is good enough. And Ernil Hansen, who is shown here, placing a unit of blood in an irradiator, believes that the leukocyte depletion filtration is not good enough. Now, and he believes that irradiation to the point of 50 gray of irradiation is necessary to kill all tumor cells within a unit of salvaged blood. Now, and this is kind of a summary of what he believes, is that in the studies that I presented earlier, that the sensitivity of the leukocyte depletion studies looking at the effectiveness of removal of the tumor cell, they were not precise enough to detect tumor cells. And he believes that there is a 4 to 5 log reduction in tumor cell lines from the leukocyte depletion filters, but he feels that it needs to be more of a 9-fold reduction or 9 log reduction in tumor cells. So the question really, I think, boils down to what is the outcomes? What do the outcome studies show? And I started questioning the avoidance of autotransfusion devices when I was at the Naval Hospital in San Diego, where we had a practice of collecting blood from prostatectomies. And at the time, prostatectomies were major blood loss procedures. We used to lose 2,000 to 3,000 mLs of blood routinely in these surgical procedures. And so we would do autotransfusion, and our practice was to run the blood through one of these leukocyte depletion filters. But then in 1990, we had a brand new technician who was running our equipment, who didn't know that we were using leukocyte depletion filters. And so for 34 patients, their blood was retransfused without a leukocyte depletion filter. And nothing seemed to really happen to them. We did a look back 10 years later at what had happened or what was the outcome for these 34 patients. And 10 years later, 32 of the 34 patients were still alive. And the 2 that did die died from cardiac causes unrelated to their prostatectomy and the surgery that they were undergoing. So there's other studies other than my single case report. This is a study that compared cell salvage in, again, prostatectomy, where the alternative to autotransfusion or cell salvage was preoperative autologous donation. And then there was a third group that received no transfusion. And what you can see is that the follow-up period of time was about 3.5 years. And the recurrence rates for the three groups actually showed that the patients that received no blood had higher recurrence rates than the patients that received their own blood via either salvage or via preoperative autologous donation. And the interesting thing is that the cell salvage patients had the best outcomes. Other studies. This is another study of pre-donation in radical prostatectomies, where the follow-up was for 3 years. This is a different study that showed salvage without filtration compared to an alternative group. And again, the cell salvage outcome was better than when compared to traditional therapy. Another study, again, prostatectomy seems to be where most of the work has been done. And then I'll show you some data from hepatectomy or liver cancer patients. These have been the two big groups. Anyway, in this study, there was 112 men that underwent prostatectomy, 48 received cell salvage, 64 were not transfused. They looked at PSA as a marker of recurrence of the disease, and found at these particular intervals of 43 and 46 months that the PSA progression in the salvage patients was less than the progression of the patients who did not receive the transfusion. However, it was not statistically significant. Another study, this time with hepatocellular carcinoma, where 31 patients underwent autotransfusion, and this time they used a microaggregate filter, which is one of those screen filters that I showed you previously. It's not a leukocyte depletion filter. And the leukocyte depletion filter, by the way, it works by attracting any type of cell that has DNA in it. Cancer cells are included in that population of cells, whereas red cells do not have DNA, so they won't be removed. So they looked at 48 and 15-month follow-ups, and this was the outcome, is that cell salvage had neoplastic recurrence in these hepatocellular carcinomas that was equivalent um, to the group that did not receive the autotransfusion. And one of the interesting things with this study was that the follow-up time was longer for the cell salvage than it was for the without cell salvage. So you would expect the recurrence rates to be higher. So this study somewhat biased against cell salvage. Here's another study in hepatocellular carcinoma where they compared 50 patients without autotransfusion, 54 patients with 10-year follow-up. And they split it out into the stages of presentation, whether or not they were stage 1, 2, 3, or 4. And what you can see here is the group 1, which is the autotransfusion group with normovolemic hemodilution, at least in the patients with stage 1 and stage 2 cancers, the outcome was better after 10 years. However, this survival advantage disappeared when their cancers were more advanced, meaning stage 3s and 4s. This is another study that was published where, again, in patients undergoing radical prostatectomy, the overall survival rate was equivalent between the populations. So number of years ago, 2012 to be precise, I collected all of these case reports and pooled the data from these studies. And what we found was that there was a slight survival advantage when autotransfusion was used when compared to traditional therapies, meaning transfusion of allogeneic blood. So there is no evidence in the available data to suggest that patients are going to blossom with metastasis when autotransfusion is used. And I think part of this relates to a misunderstanding of cancer biology. And this is some work that recognized or at least published the fact that circulating cancer cells occur in early stages of cancer. And this was recognized back in 1869, which I find to be amazing. But there have been multiple investigators that have demonstrated that cancer cells circulate in the circulation, and it doesn't seem like they have much prognostic significance. But to test this idea, this individual, Chester Southam, who was he was the vice president of the American Medical Association at the time of this study. But he took prisoners and demented patients and injected cancer cells directly into their circulation to look at whether or not they would blossom into diffuse metastatic disease. And what he found is that they didn't. There was no relationship between the injection of these cancer cells and any subsequent cancer that arose in these prisoners and these demented patients. Chester Southam was ultimately disbarred from the American Medical Association because of these studies and the lack of ethical standards which were associated with this study. But it is quite telling that the mere fact of injecting cancer cells into circulation does not lead to subsequent cancers. So if you apply that to autotransfusion, it should make you skeptical that this is an issue. So one of the things that has been discovered with increasing understanding of cancer biology is that circulating cancer cells and subsequent metastasis, the whole process is extremely inefficient. Most micrometastases actually go out, get extravasated into the subsequent or the tissues around the blood vessel, and they just die. And they don't really generate micrometastasis or small growths of cancer cells. And in fact, these two studies that looked at men in their 40s and women in their 40s found circulating cancer cells in a high percentage of these patients. And with the idea that these circulating cancer cells basically go on to suffer from apoptosis or cell death without causing a cancer. And so this is an individual that I heard, Jacqueline Bissell, at a meeting, and she's a fairly prominent cancer biologist that you can go on to into the TED Talks and find her give a presentation about other controlling factors that lead to cancer growth. And she believes that there is signaling that takes place from the extracellular matrix that is important for malignant cell growth. And she's primarily studied breast cancer, and in concluding that it requires this extracellular matrix to signal to these cancer cells to grow. There's also a theory of seed and soil, meaning that you have to have a seed, but you also have to have a soil that favors progression of these cancer cells. And it requires basically a vascular structure associated with that cancer cell for it to actually grow. And so there are angiogenic stimuli, and then you have the opposite, which is apoptosis or cell death, that you have to have the angiogenic stimuli to get the cancer cells to grow. So many of the cancer chemotherapeutic agents are aimed at basically blocking the vascular structure. And this particular slide just shows you what that looks like, is where you have a cancer cell, and it's necessary to have the blood circulation grow into any tumor cell in order for it to grow. So again, you have anti-angiogenic drugs that have been designed to try to prevent that growth. So these are some of the regulators of angiogenesis. There's negative and positive regulators, and it's interesting that some of these positive regulators are actually found in higher concentrations in allogeneic blood that's been stored, and which may account for why we see higher rates of cancer growth in patients that have been transfused with allogeneic blood, is that they have these positive regulators. So there is some interesting technology that has been developed in Germany by a company called Lindus Blood Care, where they have developed a monoclonal antibody that is attracted to an EpCAM receptor on tumor cells. And apparently this is a universal receptor on a cancer cell. So what they have is a monoclonal antibody that will bind to that EpCAM receptor. And then they advocate doing the normal processing of autotransfusion and leukocyte depletion. But because the monoclonal antibody makes the bound cancer cells so large that they won't make their way through the leukocyte depletion filter. So it's interesting, if you do have this fear of these cancer cells and don't believe that the leukocyte depletion filter is adequate, then this particular monoclonal antibody would give you a higher level of comfort. At least that's the hope. In Germany, it's mandated by law that a radiation is used for autotransfusion blood. And so that's what led to the development of this Lindus blood care technology. Personally, I don't feel like we need to go that far. I think the leukocyte depletion filters are probably adequate. But I think, at least in my practice, it's been very difficult to convince cancer surgeons or oncologic surgeons to use autotransfusion. So I think that the Lindus blood care monoclonal antibody and what it gives in terms of an extra layer of comfort for the surgeons would allow for higher growth of this particular technology, or rather autotransfusion in cancer surgery. And it's one of the big areas of opportunity for using autotransfusion. So this is an editorial that I wrote with Albert Donnenberg, who is a cancer biologist at the University of Pittsburgh within our Hillman Cancer Research Center, that basically the preponderance of evidence appears to support the use of blood salvage in cancer surgery. And at this point, the use of the leukocyte depletion filter appears to be prudent. So I will end my presentation there. And if anybody has any questions, feel free to reach out to me. This is my email address where you can reach me.